Welcome, everybody. I'm Johanne. I'm the head of the course that's running now, which is on sexual and reproductive health and rights for PhD and master students at the University of Oslo. And this open lecture is part of that course, but it's also an open lecture where we have invited Eszter Kismödi, who lives in nearby Geneva, who's a lawyer of background and has worked in the World Health Organization and as a legal advisor, and also is the editor of the journal Sexual and Reproductive Health and Rights Matters, or Sexual and Reproductive Health Matters. And she has been teaching in our course before, so we know her, but now we have given her the task to actually inform us hot topic on sexual and reproductive health and rights in the era of COVID-19. And I invite you to share your presentation with us on the screen, Eszter, and start telling us about what you think around it. And then after she's presented her work, we open up for questions and answers through the chat function. That's the button at the bottom of your screen. You can type in your questions there, and we will take them after the lecture. Welcome, Eszter. Get going.
Thank you so much. I really appreciate the invitation and the opportunity to talk to the students. Usually we are talking together and we are talking with each other, and it's just a new form of communicating. It's very unfortunate that we cannot see each other, but this is how it is, and it's great that technology allows us to do it anyway. So I would like to talk about the implication of COVID-19 on sexual and reproductive health and rights globally. And I really would like to especially inject a human rights lens into my thoughts and to my presentation. I don't know how to, okay. So there is an increasing evidence and documentation that shows that that there is a dramatically that during COVID-19, the pandemic and the programmatic response and the political and policy response to COVID dramatically altered the programming landscape for sexual and reproductive health and rights. At the beginning of March, we were holding Sexual and Reproductive Health Matters. The journal was holding a seminar, a webinarium, when we had 3,000 participants that actually showed that there was so much hunger to get information, and we didn't have too much information at that point of time. 3 months passed, and we really have more and more evidence and documentation what is happening. We are getting reports and evidence and data from different parts of the world, including from low and middle income settings. So what do we see? We see a widespread shortages of products in the supply chain in terms of high quality contraception, lack of availability of essential drugs for people living with HIV, transition related to care for trans people, absolute lack of services for people living with disability. It's also very interesting to follow that how the shortages flow. At the beginning, because China was under lockdown, all the supplies couldn't come from China. Then it moved to India, but transport was not available. And now there is more question is that how states and governments prioritize to fill the gaps and make services available and accessible for the population. There is reported number of closure and reduction of abortion and post-abortion care services because they are considered non-essential under strict lockdown orders in several countries. In several countries, sexual and reproductive health services, not only abortion and post-abortion services, are closed. In some countries, even maternal health services didn't function for several weeks. the closure and the lockdown is also significantly, and the restriction of movement restrict the mobile outreach team operations in remote and rural and underserved urban location that has been suspended in several countries, and it really affects a large proportion of the population in many countries. There is increased stigma towards marginalized population, and I will talk about people with disabilities, trans people, refugees, lesbian and gay populations, sex workers, and also against healthcare providers who provide health services such as abortion, transition-related care for trans population, those cervical cancer treatment, IVF treatment that are labeled non-essential services. So I would like to investigate particularly two questions. What will it take to ensure sexual and reproductive health and rights during emergencies such as COVID-19? And what is the human rights imperative, the public health and human rights imperative around that? And especially for those who are most marginalized. The COVID-19 pandemic has placed a significant strain on local and national health systems, and this government prioritization of healthcare services in many countries, as I mentioned, labeled most SRHR services as non-essential. We know and we learned that over the past decades, especially since the conference and the conference document and the agreement on population on ICPD, International Conference on Population and Development, and the ICPD action, there is very clear recognition of the respect, protection, and fulfillment of sexual and reproductive health and rights as a matter of human rights, and that availability, accessibility, affordability, acceptability, and quality of sexual and reproductive health services is not only a public health, but also a human rights question and imperative. So we have well-settled standards in general around how governments and states are allowed to restrict human rights, and on what basis restrictions of human rights are justifiable due to special circumstances and due to emergencies. The principles that are governing the permissible limitations of human rights are called Syracuse principles. And the Human Rights Committee, the United Nations Human Rights Committee, issued a statement most recently in April that reinstated these principles. So these principles are set, what are the permissible limitation of human rights? And I'm listing those that I'm examining in my lecture. So they are those that are provided for and carried out in accordance with the law. So there has to be legal measures to restrict certain human rights. The restrictions needs to be based on scientific evidence. They need to be directed towards a legitimate objective. They need to be strictly necessary, the limitations, strictly necessary in a democratic society. They need to be least intrusive and restrictive means available, and they cannot be arbitrary, non-discriminatory in their applications. They need to exist for a limited duration, and they need to be subjected to regular review. So how these permissible limitations worked out in the past 3 months during the lockdown in many countries and during the restrictions in many countries, and what can we learn from that? We are learning about, or we are expecting second or third waves. We are expecting the ease of the restrictions and the lockdowns, but it may come back, maybe not in relation to COVID-19, but in relation to other emergency situations. So what do we learn? Whether these restrictions that have been applied in many countries were permissible or in fact against human rights standards. After 3 months, the documented and estimated harm from restricting access to sexual and reproductive health services are considerable. We are hearing from international organizations like Mary Stopes International, the International Planned Parenthood Association, IPAS, and other services about the documented impact. It's very interesting to see actually some estimate from the Guttmacher Institute, who put out a very valuable report 2 years ago, in 2018, called the Guttmacher Lancet Commission Report on Sexual and Reproductive Health and Rights, that really, in the context of ICPD plus 25, put sexual and reproductive health services in the center of attention. So the Guttmacher Institute came up with some estimates based on already existing evidence that estimates the impact, the expected impact of the restrictions on sexual and reproductive health services on women's health. According to these estimates, in case of 10% proportional decline in use of short and long-acting reversible contraceptive methods in low and middle-income countries due to reduced access would result in additional 49 million women with an unmet need for modern contraceptives, and an additional, sorry, I lost my screen. Oh, sorry. Just 1 second. And an additional 15 million unintended pregnancies over the course of the year. Again, these are estimates based on already existing evidence that exists on already existing beyond the COVID-19 restrictions in many countries. According to these estimates, even in a case of a modest decline of 10% in coverage of pregnancy-related and newborn healthcare, an additional 1.7 million women who give birth and 2.6 million newborns would experience major complications, but would not receive the care they need. Again, it's an estimation over a course of a year. This would result in additional 28,000 maternal deaths and 168,000 newborn deaths. If abortion was considered a non-essential service, so that 10% of women, that is an underestimate, who would normally have a safe abortion instead of resorted to an unsafe method, and an additional 3.3 million unsafe abortions would occur, with significant number of additional maternal deaths. So this was about the evidence. So as we heard, there was a conversation in BBC yesterday that said that governments and states are imposing restrictions because they want to save health and life. This evidence, and looking at the evidence in the context of proportionality of imposed measures, we also have to see that what kind of impact the restrictions have on life and death beyond COVID-19 caused or associated morbidities and deaths as well. When we are investigating the Syracuse principles on the subject of the least intrusive and restrictive measures should be applied, a complete lockdown and closure of services and not filling the gaps in terms of supply shortages, questions that this complete lockdown, complete closure, whether it's the least intrusive and restrictive measure. After 3 months, we really realize when there is willingness and commitment and accountability for the provision of safe of sexual and reproductive health services, provision of services is possible. Good practices from various countries shows that state could facilitate a wide range of alternatives. For example, provide safely self-managed medical abortion, contraception, including emergency contraception via telemedicine. Waive requirements that entail one or more clinical visits that are anyway, all these waiting periods and authorization requirements are already considered to be contradictory to public health interest and human rights standards. Waiving them, including the mandatory waiting periods, would ease access barriers. Removing or suspending criminal penalties for self-managed abortion would allow women to go for safe abortion services instead of applying unsafe methods. Exploring partnership with online pharmacy retailers for sale and distribution of essential sexual and reproductive health products proven to be a very effective method in many countries. When it comes to HIV, simplified antiretroviral therapy delivery models for those who are safely managing, those who are women living with HIV and breastfeeding and being pregnant, and women who are already on treatment, would include the multi-month prescriptions and dispensing, providing 3 to 6 month supplies that happen to be in several African settings, for example, that would reduce the frequency of the visits to clinical settings and ensure continuity of treatment during possible disruption of movement during the outbreak. The same applies to people who inject drugs and who live with HIV, who are clinically stable and could get methadone and buprenorphine substitution with an increased possibility for take-home medication to decrease the burden on the health sector. These are positive practices that has been documented during the past 3 months. When it comes to the Syracuse principles on permissible limitations, and that the limitations shouldn't be discriminatory and disproportional on certain population groups, we have the documentation and the evidence that shows that in fact the arbitrary and discriminatory nature of state actions that have been applied during these past 3 months in various countries is overwhelming. And it applies to women and girls, especially rural women and girls and adolescents. And I will talk about violence against women, for example. Women living with disability has a disproportional impact on their health and life. Transgender people, sex workers, people living with HIV, those who are living in humanitarian crisis face particular difficulties in accessing services. In all of these cases, restrictive measures in the absence of the provision of alternative services means that these populations are disproportionately and discriminatorily affected by service closures. So it's really this documentation is very important, and in the context of human rights, in the context of public health, and in the context of government measures, we need to learn what kind of discriminatory measures the service closures has on already marginalized populations. It's really impressive that how quickly authoritative bodies such as WHO, the Federation, the International Federation FIGO on Gynecology and of Obstetrics, UNAIDS, the United Nations Human Rights Refugee Agency, and other actors, the Office of the High Commissioner for Human Rights, came out with guidance how to provide services during COVID-19 and during similar crises in relation to sexual and reproductive health services, including in relation to maternal health, access to abortion, management of gynecological cancers, in relation to contraception and family planning, violence against women, and provision of healthcare services in prisons, for example. Let me give a couple of examples, and very specific examples in relation to particular sexual and reproductive health matters. I think it's very well documented, it's picked up by the media, it has been well discussed in the past 3 months, and that how violence against women and girls and many other vulnerable populations as well has spiked throughout the world in countries that have implemented restrictions and lockdown measures to control COVID-19. With significant reports of intimate partner violence to the police, to social services, to hotlines or shelters, doubling or even tripling, including all over the world, from China, from Europe, from France, from India, and in many other countries. Intimate partner homicide, the most fatal outcome of intimate partner violence, is also documented to be rising, with, for example, 3 times as many women murdered in the UK during the first 3 weeks of lockdown compared to any equivalent time period in the previous years. And it's estimated that even with the easing and ending of lockdown measures is unlikely to result in a reduction in violence against women and girls. Why? Because the increased levels of stress due to economic uncertainty that has been documented in many other crisis situations as well, health fears, the imposition of lockdown exert more control by abusive partners, stress, the disruption of social and protective networks, and decreased access to services can all exacerbate the risk of violence for women. The looming recession and economic uncertainty, the key predictor for intimate partner violence, will mean that families will see the disruption in their livelihoods, including food insecurity, and this in turn will exacerbate stress, question existing masculinity norms around the male breadwinner model, and thereby increase conflict in relationships. Violence against women and girls is preventable. Over the past 2-3 decades, we have evidence-based guidance that shows how to prevent and deal with violence against women and girls, sexual violence and domestic violence, community awareness, information and education, providing safe places, cash transfer programs to ensure economic independence, and health system response among the key pillars of responses that also applies, as the past 3 months shows, in crisis situations such as COVID-19. The French and the UK governments and other governments as well, as an example, have decided to offer hotel rooms, for example, to women who experience intimate partner violence during lockdown, and pharmacies across the world, including from Peru to Italy, have developed a designated code for women, probably as you heard about, that they can use to indicate the need for assistance against domestic violence. For COVID-19, WHO specifically calls on health facilities to have information on local and accessible providers and format for women who face violence. They also call on health providers to be aware of the risk and health consequences of violence against women, and call on and many international institutions and evidence-based response call on governments to consider health services to deal with violence, with the consequences of violence as essential health services, and make them available, accessible, affordable, and in good quality, meaning confidential, providing dignity, and respecting privacy for women and for those who are reporting to them. Let me also explore the consequences of COVID-19 and the measures that has been applied during COVID-19 for two other marginalized, vulnerable populations. When I talk to our colleagues and partners in Kenya, for example, Lizzie Kiama, who is leading a global and African and Kenyan response and documentation to COVID-19, she started her conversation telling to me that persons with disability have lived with this reality for ages. It's not this lockdown, these restrictive measures are not new to us. We have had to live in isolation before social distancing became a global trend, because transport, food security, health services were restricted and not available and accessible to us. The difference is that the difficulties are even more exacerbated, and the discrimination against people living with disability, especially as it comes to sexual and reproductive health services for women and girls living with disability, is really deepened. So, for example, when it comes to access to information, she says that the assumption is that increased use of technology will deliver crucial messages, for example, through social media. However, and sorry for the misspelling on information, however, the assumption is that social media reaches people and women and girls with disability is false. A lot of women and girls and people living with disability have no access to social media and internet in many settings, and alternative information technologies and means, including on the basics of hygiene, were or not available. There is also an assumption that everybody can access information in readable format and through radio or television, when people with hearing impairment or other impairments read messages in written format or through the radio might be not available. So they are even more furthermore marginalized in this situation. The link between poverty and disability becomes even more pertinent in the time of a crisis. Access to water and sanitation services, for example, puts persons with disabilities and living in poverty at the risk of infections. Many persons with disability are dependent on assistance to get clean water and access to services. And in the lockdown measures, when assistance cannot reach people with disabilities in their home, they are completely isolated from essential services, not only in terms of health services, but also food, sanitation, hygiene, and water. That also includes menstrual hygiene products, contraception, medical abortion services. It's also important that to mention that legal capacity, although legal capacity is an issue is a human rights matter for people living with disability, including for those who live with intellectual disability. A lot of people with disabilities, whether mental, physical, intellectual disabilities, in terms of accessing sexual and reproductive health services, dependent on the authorization of their guardians, who are very often the violators of their basic human rights, and they are not the ones whom they could turn to help when in terms of accessing contraception, abortion services, or condoms, or seek advice and assistance in case of gender and sexual-based violence. Women and girls with disabilities face without COVID-19 situation increased sexual violence than non-disabled women. It is estimated that 40 to 70% of girls with intellectual disabilities will be abused before they reach 18 years of age in a non-crisis situation. So the question is, and evidence is not yet available, but being continuously documented, this number can double, triple in confinement periods, and when services, shelters, safe places are not available for those women and girls and those populations who are at risk. When it comes to transgender populations, and I would like to talk about the transgender populations because it has, from a sexual and reproductive health and human rights perspective, trans people face human rights violations on a daily life, such as people with disabilities. When I talk to colleagues, transgender colleagues, that what is happening, what is the situation of people, of trans people, the answer was that more of the same, but worse. It's the crisis and the COVID-19 situation and how it is being handled, not imposing radically new challenges, but deepens already ongoing violations and challenges. So what are those? Many trans people, including trans sex workers, depend on the informal economy. Their sources of income have disappeared, and in many places they are not eligible for economic support, or that support is just simply not available. For trans people across the world, the stay at home is an impossible directive, since many trans people don't have access to housing, stable housing, or even to shelter. And homelessness is a very unfortunate reality, and connected to injustice reality, common reality for many trans people. In several countries, strict quarantine measures are being enforced by the police and or the military officers, which increases already chronic overexposure to police brutality for trans people in some countries, and there is documentation from, for example, Peru, Panama, Colombia. Those measures included gender rules for individuals' mobility, which adds an extra layer of institutional abuse against trans people. many individuals are forced to share their quarantine time with unsupportive families, and there is a documented increased risk of gender-based violence that transgender people face. In many countries, gender-affirming healthcare has been postponed and or cancelled, when in fact, for example, hormonal treatments such as contraception could be easily available for trans people. In some countries, such as US and Brazil, trans people access to healthcare as well to other basic goods, including food, depends on the goodwill of administrations who have been explicitly involved in suppressing their rights and discriminated against. Some countries, for example, Hungary, use the opportunity to adopt laws that are against human rights standards and deprive transgender people from gender recognition. So, as a conclusion, there are two interrelated pandemics we are facing, in my opinion, and the opinion of several of my colleagues. One regarding the health, and the other is the socio-economic one. The impact is from the pandemic itself, and also from the measures to combat it that are coming up against underlying factors, such as entrenched inequalities and weak health and social protection system. COVID-19 is showing us that universal health coverage, UHC, including reaching those who are vulnerable, is a public health and the human rights imperative. The impacts will continue to fall disproportionately on women and girls, on marginalized populations, the same populations that have long experienced barriers to access to sexual and reproductive health services because who they are, or what they do, or what they need. So I stop here, and I would go back to Johanne and to get some questions and have some conversations around the topic.
Yes, and I would like to welcome everybody, and there's 55 people or so on the list to post questions on the question and answer chat, or especially on the chat maybe, because that's where we are operating. If you want to ask questions, or if you want to have a debate around those things, please, this is the time to get going. I can't see that many questions yet. Here's one coming in the question and answer. My name is Eva Matrich from Carlos University in Madrid. Many thanks for your great presentation. I would like to ask you about the COVID-19 and the consequences for teenage pregnancies. Do you think that teenage pregnancies could increase, and if so, why? Do you want to answer that orally?
I can go ahead, and maybe Johanne, you also have some remarks on that. There is actually a documentation of increased teenage pregnancies. And I think I wish I could ask back the question from you, what you think, because I think it's as it comes from the presentation as well. There is, first of all, contraceptives are not available in many settings. And sometimes it's not only from the unwillingness of the governments to provide them, but because they are the distribution channels are stuck, and the supplier chains are not necessarily, and contraception and condom is not necessarily the priority in the provision of many different services competing, including food and many other hygienic supplies. The second one is that because in the confinement, mobility is restricted, teenagers might not be able to reach services for emergency contraception or safe abortion services. And the third one that is interlinked with the other two, many teenagers are abused in the domestic settings by their siblings, by their uncles, by their father themselves. And they are the very people who would need to give permission to them to seek services. So the whole trust, dignity, and access chain is compromised for young people in this situation. It's not only for girls, it's also for boys, transgender people who may be able to have sex but have no access to condom and protection. So yes, it's a clearly documented risk. Johanna, would you like to add anything?
Yeah, I think there are quite a few hypotheses that it may increase. I think it's a bit early to say whether it has, because we need to see what happens. I mean, for a pregnancy to realize itself and be visible, it takes a few months. But I think some types of teenage sexuality maybe will go down, like those who do these internet-based matching programs. There has been a warning against going out and being with somebody that you meet on the internet, because the situation is different. But we also know that people are more confined in the home, and in the home there's not that much to do, so that maybe more people are just resorting to all sorts of different experiences and sexualities, and so I really want to see what's going on and see how it looks after 6 months, because then we will know more about it. And the world is so big, and there are so many young people, and there are so many young people have problems practicing social isolation. So we'll see. I'm also, and that goes maybe to the next or some of the other questions around negative consequences, or the whole issue of contraceptives, both whether there are negative consequences of providing contraceptives without prescriptions, or maybe one will have to resort to older methods of contraception because you don't get commodities, and you have to relearn the methods that we used before one had modern contraceptives, or if that is like a no, you should not go that way. You should still say that you can't practice natural contraception or old-fashioned contraception. There are so many unanswered questions around it. We are now getting questions both on the chat and on the questions and answers, but there was one on contraceptives. Maybe you'll address that.
Yeah, I'm just not sure whether the question is that it's about the negative consequences of providing contraceptives
without prescription.
With prescription. So the negative consequences that you need prescription.
Yeah, well, that usually you need prescriptions, but now you may have a looser system.
I think, I mean, if I can answer the question, that there are positive, good case studies when the whole eligibility criteria based on prescription and doctor appointment have in accessing contraception, including emergency contraception, has been eased in different settings, because going to gynecologist or obstetrician or even to a GP was just not a reality, and this kind of criteria was eased in many settings that allowed people to access contraception. That is clearly managing STIs, unwanted pregnancies. Whether it has, I don't know if the question was about the negative consequences. I cannot comment to it, I think there is documentation that actually prescription-based, for example, emergency contraception is a barrier to protecting health of women, and also life, in terms of unsafe abortion, preventing unsafe abortions, and strict prescription-based access of contraception and emergency contraception is acting against health interest and human rights standards. I hope I answered this question. I would like to go back to Arpita, who was asking about the caste identities. And I'm not necessarily an expert on this topic. There were some excellent webinars in the past week that are available, for example, by CRIA, about social inequalities, sexual and reproductive health, feminism, and women's rights and health during COVID-19. The caste system, as it comes to sexual and reproductive health services, is really pointing to intersectional discrimination as well, that how caste-related inequalities are manifesting in, for example, access to jobs, and access to daily income, access to security, and also in terms of access to limited services when it comes to affordability. So I think there is a very greatly documented correlation between caste-related inequalities and intersectional discrimination in relation to accessing sexual and reproductive health services.
There is a question in the chat from Tanmay. The question reads, how will the pandemic affect the funding for SRH programs in low and middle income countries? If you know anything about it. Now all funding, also research funding, goes to COVID. Well, what happens to funding of sexual and reproductive health programs?
I think the answer probably is multifolded, because on one hand, I think we can see increased support from governments, for example, the Nordic countries, Canada, Germany, and the UK through DFID, for example, to providing extra support for the provision of sexual and reproductive health services, research and documentation during COVID-19. However, foreign aid always dependent on the economic situation of the given country. So I think it's really worrisome that how governments will be in a situation when they need to prioritize their domestic needs vis-a-vis their foreign support, and how it will affect the provision of sexual and reproductive health services in low and middle income countries that are, in many settings, are dependent on foreign aid. And I also need to mention that some governments, like the US government, is using this opportunity for a political for exacerbating the political tension around the provision of sexual and reproductive health services. Sexual and reproductive health matters is coming up with a special issue in the fall that are run by, that is based on research by the Columbia University of documenting the impact of the global gag rule, the devastating impact, and we will especially in 3 countries, Nepal, Kenya, and Madagascar, that shows that the deprivation of foreign aid, US aid funding on safe abortion services and many sexual and reproductive health services, what kind of detrimental effect it had. So using the pandemic and the COVID-19 crisis to create a political turbulence of the provision of safe abortion services, even in settings when provision of safe abortion services are legal, is a very dangerous game, and a very dangerous move that can seriously affect on women's health and life.
Unfortunately, I'm having a lawnmower outside here, so the noise is a bit disturbing. But maybe you could also look at the question from Salma on preventive measures in response to domestic and intimate partner violence. You see it's the third question in the Q&A queue. And then after that, I'll take up something else.
Yes, I think it's, I would recommend, I think we don't have a lot of time to go into details, and I'm not necessarily the technical expert on this subject, but I would like to recommend to look at the WHO website on violence against women, for example, and there are many other sources as well, that gives, based on already available evidence, the situation, for example, in Sudan and many other countries when the government and the state is not recognizing violence against women necessarily as an accountability as a matter of accountability for the provision of health services, is really even more exacerbated in the COVID-19 situation. Guidance is really available that, as I said in the presentation, is very similar guidance in terms of safety net, in terms of shelter, in terms of economic independence, and in terms of health system response. In this situation, for example, in many countries, when it comes to the legal system, it's not only that the legal system is not recognizing, for example, marital rape as a form of violence. So women has even no resources, no legal recourse for remedies in this situation. But when in this situation, women are reaching the health system, in many countries, the law imposes reporting requirements on healthcare providers to the police. And when the perpetrator is the husband, or the perpetrator is the person whom women are confined with in this situation, women really have no resources to get protection and services. So in this situation, I think it's really like almost putting a lens on these situations, that these legal systems need to recognize the realities that violence is happening in domestic settings, and very often it's non-consensual, and women need services.
There is one question that has come up from both me and from one of the participants as an experience. When we started to practice social isolation, a lot of people who were pregnant became very anxious, because first, when women are pregnant in an epidemic situation, they're anxious that the virus and exposure and could harm the fetus. I mean, those are the first things that come up. And then also that infection in itself could be dangerous to pregnant women who are getting sick. But then one thing that came up as a result of policy is that instead of giving birth in a birthing home where the husband gets to be present during the delivery, and the couple get to stay together for a couple of days after the delivery, a few birthing systems started to either not even let the husband in when the women delivered at all, or he was kicked out immediately after birth, so that the status of the man was seen as okay when the delivery was taking place, but the support of the husband in the postpartum period was taken away. And I heard a lot of discussion around that from women in my country, that they didn't understand what the argument was and why this was institutionalized. Do you know anything about the situation in other countries, Eszter, on issues? I mean, having the husband present at birth has been something that we fought for maybe 20, 30, 40 years ago, and now it's a routine, but all of a sudden it was taken away.
I think it depends on the situation, and I think there are documentation on various measures. I think in most of the countries there were restrictions for the protection of the healthcare providers and for the protection of the women and the babies and the newborns in the healthcare facilities. I think alternative like home delivery has been also promoted with a clear emergency availability and accessibility in case emergency occurs in several settings. I would also recommend the looking at the FIGO guidance, and it corresponds with the question, I think, from someone who said that there was from Nepal, there was two deaths in, I'm sorry, I think the question disappeared, that there were 2 deaths and what would be the recommendations in relation, Niru Lama, that we had 2 deaths of women after a few days of delivery. What do you suggest on these situations? Again, I think we shouldn't, and maybe Johanna, you can come back on that for 20, 30 years documentation on how to deal with maternal death, also leading back to delays, to the 3 delays, the delay in accessing healthcare services, the delays in getting emergency care, and what is the 3rd delay, Johanna? So it's not different than COVID-19 in terms of you need to deal with this, addressing these delays that are documented reasons for maternal deaths. Johanna, do you want to come in on the delays a little bit? Because I think this is what is being documented, that transport is not available, services are not available. I think it's also, as you can see, the deaths and including the maternal mortality-related death, marginalized populations are not getting into the hospitals, whether it's connected to color, caste, socioeconomic status, because the discrimination they are facing. So I think whatever we are documenting in terms of the reasons and the causes of maternal deaths that are really deeply embedded in non-discrimination in many ways are being seen in the COVID-19 situation as well.
I've seen both what I would call panicky responses to the COVID and pregnancy and delivery, that some institutions have just like said, we don't want anyone to come. You can't come inside the house because we think everybody could be infected, and that has also led to delays in getting access to delivery care because people have been stopped and they are required thorough investigations or a little bit overdone. But we can see why people do that in the beginning, because they panic. I've also seen some examples of really good responses by healthcare providers in Norway. There was an article about somebody who knew that there was a pregnant woman who had a COVID infection and she was about to deliver. And they actually rehearsed the whole delivery setting in the delivery ward before she came. They did a full practice rehearsal so that when she came 2-3-4 days later, they knew what to do and they could do it very, very professionally. And the husband could even stay around because they thought that since he had been around already quite a long time, it didn't matter whether he was around for 2 more days, and they left him to take care of the woman more than the healthcare providers. So in that sense, they protected the providers, and it all went very well. And fortunately, she was not very seriously affected. But I think I think there is a bit of overreaction that tends to make services less accessible and maybe of smaller quality than before because people panic. And I also think that there are good and smart healthcare providers that can adapt and can tailor services so that they do take care of those that need to be taken care of. For instance, you can't postpone childbirth. It comes when it comes. So you need to be prepared for it. You may like I said there, I can't see why, for instance, abortions should not be an essential service, because if you don't do abortions, you'll certainly have it as a childbirth some months later. So, whether you do something now or in 1 month or 2 months, it's the same kind of setting. You need to provide services.
Safe abortion services are not services that can be delayed.
No, they can't. Some people say they're non-essential. There are more questions.
Yeah, so just going back to the husband participation, I think it's really important to go back, and that's why I constructed the presentation about the Syracuse principles. And as public health master students, PhD students, it's really important to know about the Syracuse principles and use them in terms of proportionality and necessity. Is it really necessary, for example, and is it proportional? Maybe it is, but alternative methods can exist. For example, when some previous generations, there were windows when you could show the baby and you could talk to the husband. And I think this is what has been like some good practices in Sweden, Switzerland, and in other countries. Like when it shops, they managed to put a plastic counter that protected the providers and the women from possible infections. It also provided interaction through different means. And going back to Alexandru's question that how should everything we learn now be included in the preparedness planning? I think it's an excellent question, because I think it's pretty impressive that after 3 months, how much we learned. And we know how much we could do better. Good practices are being documented. They are out there. So I believe that with the ease of the situation and with the possible second wave and further restrictions, there is much more knowledge in a less panicking sense to apply than it was in March. But what is really important, that there is a government willingness and to do so. And it's really important to reinstate that how sexual and reproductive health and health services are essential services in many instances, and how the government has an accountability to provide them in alternative ways. For example, as I said in my presentations, we need to reinvestigate those barriers that has been listed, the prescription, the waiting periods, the authorization requirements for adolescents and from women, from husbands, to really release criminalization of many of these services, restriction on access to information that really need to be abandoned, those barriers in these situations, in order to save lives and health of women and all different populations.
Let me see. There is one guy here who has asked something about prevention of, did we take it? Prevention of gender-based violence and an intervention that could be aimed at men. I just wonder about the whole gendering of the home situation after the COVID. People are confined to the homes. And one of the most horrifying articles I read was that confining scientists to homes with kids hit women and men so differently that men increase their publication rates and women decrease their publication rate when they're in the home, because the women scientists that are in the homes, they take care of the kids. And the men scientists that are in the home, they don't even have to travel back and forth to work. They can sit at the computer and do all the science work and publish. And I wonder if there's also a need to document some other going backwards in gender equity that may have implications both for sexual and reproductive health and rights and for gender issues in particular. Do you want to say something about that, Eszter? Or somebody else want to say something about that? Are we losing gender equity milestones through this epidemic?
I think it's really important to consider that gender-based violence, although it's affecting women and girls proportionally, boys and men and transgender and intersex people are also facing violence. And I think there is excellent guidance, again, in the non-COVID situation about male involvement. There is also excellent resources about how we need to deal with any kind of violence happening against any gender. And I think those guidance should be used in the given situation as well. And I think, but there is so much, like we are experiencing so much stigma, taboos, and discrimination when, for example, men, boys, transgender people are going for health services, seeking assistance against sexual violence. So I think we can do a lot about elimination of the discrimination and stigma within the healthcare settings. Or there is a lack of knowledge how to deal with sexual violence against men and boy and transgender population. So we need more information and education within the healthcare system as well, how to deal with those services.
Yeah.
I think there is a very it's a very important question about sex workers.
Mm-hmm.
And I partially touched upon this in my presentation, but there is excellent documentation from various global and local sex worker organizations. And again, like for the disability community, for the transgender community, again, the discrimination, the violence, the poverty, the insecurities, the socioeconomic insecurities that sex workers are facing, they are facing it without COVID as well. But it's really just deepens. What I think is a major impact on sex workers that they are dependent on social interactions in terms of the work, what they are doing, and when it's being forbidden and policed, then sex workers are deprived from their income that provides not only for them but for their families as well. Similarly, like transgender people, because most of the sex workers are working in the informal sectors, they are not eligible for social protection and for help and assistance. There are positive practices when sex workers are registered, when sex work is considered to be an acceptable employment. In those limited settings in this world, sex workers are also eligible for assistance, protection, and aid as well. So in this situation, it also shows that how sex work as work and as a kind of autonomy in terms of income generation is a question of sexual justice in many ways, and socioeconomic justice as well. But there is a great struggle of sex workers, those who are dependent on this income. There is an increased police harassment and brutality against sex workers, especially those who are earning their income on the streets. So I think the sex workers community, and as it is being documented, is facing a very serious burden in this situation.
I think it's about time to round up now. I think we've covered most of the questions that were posted, and also been exploring the corners of sexual and reproductive health and rights in the ongoing epidemic. I think we will have to have a seminar in 6 months from now to sum up what the...
It'll be very interesting, I think.
And I thank you so much, Eszter, for coming forward and being part of this course and this open lecture. I've learned a lot, and I think everybody else they were very active participants. So thank you so much, and continue asking questions.
Thank you so much, and I really appreciate the questions and your interest and the invitation. It was, as always, really delightful to be with you. Thank you very much.